Welcome. Today we are going to learn how to perform reduction of a pediatric hip dislocation by East Baltimore lift technique. An 11-year-old child presented to the emergency room with a history of a road traffic accident with trauma to his left groin and knee. On inspection, the patient had a deformity in his left lower limb and he had an attitude of flexion, adduction, internal rotation, and gross shortening of the left lower limb. As the patient was painful in the left groin and knee areas, X-rays were ordered for the child. Now, after following the ATLS protocol, the patient was sent for an X-ray, and this is the X-ray that we got. This is not a true AP view, but an obturator oblique view that we got. So here, the first striking thing was a posterior dislocation of the left hip, as we can see in the X-ray. Other features that were noted were fracture of the superior and inferior pubic rami, as shown with the arrows. If you observe closely, there is a disruption of the pubic symphysis with a uplifting of the left hemipelvis. The knee X-ray were taken, and this was the views that we got. Here we can see that it is a valgus impact force that has happened to the left knee, and if we have a closer look of the proximal tibia, we will be able to find that there's a Salter-Harris type 2 physeal injury with a Thurston-Holland sign and a fibular neck fracture as well. So now we are going to demonstrate the reduction of this pediatric hip dislocation by East Baltimore lift technique, and after that we'll reduce the knee injury and apply an above knee plaster of Paris slab. Now in this East Baltimore lift technique, the patient lies supine and two clinicians, they stand on the opposite side of the patient at the level of the pelvis, and the dislocated limb is flexed at the knee and the hip at 90 degrees. Then the two clinicians, one on either side, they place their arms under the patient's calf or popliteal fossa, hooking their elbows and resting their hands on the each other's shoulder. Now a third person is required to stabilize the pelvis, and a traction will be given when the two clinicians stand up while bending their knees. So an upward traction force is given to the femur. Simultaneously, the third person will keep the pelvis grounded and give a counter traction. So this is the procedure by which we reduce the hip by East Baltimore lift technique. Here you can see in this video, the two clinicians have flexed the dislocated limb at the knee and the hip at 90 degrees, and they are putting their forearm beneath the popliteal fossa, and they have rested their hands on the opposite shoulder of each other. A third person is giving counter traction, and here once we give traction, you can see that the hip reduced. The hip got reduced. So once the hip is reduced, the deformity disappears and the patient becomes comfortable. So a clunk can be heard or felt during the dislocation reduction. Now, important thing post reduction is to check for the peripheral pulses. Here I am palpating the dorsalis pedis artery which was present and the posterior tibial artery. Both pulses were palpable. Now I'll try to do a telescopy test, in which what I'll do is I'll flex the knee and the hip to around 40 degrees and I'll give a posterior translation. So here I'm flexing the hip and the knee to around 40-45 degrees, and I'm trying to push it posteriorly, but the hip is stable and there is no dislocation. So this is a stable hip after reduction. So this is the pre-reduction photograph or the attitude of the lower limb. Here you can see that the child had initially a flexion, adduction, internal rotation and gross shortening of the lower limb, which is characteristic of a posterior dislocation hip attitude. So on the photograph on the right side of the screen will be the photograph after reduction, wherein the deformity has been corrected and the length of the lower limb has been restored. Now once the hip dislocation has been reduced and it is stable, now we'll try to focus on managing the injury the child has sustained in his proximal leg. My colleague is preparing a slab by making use of a 6-inch plaster of Paris roll bandages. He is making a slab. So before we do the reduction, we will be uh, preparing all the things that we would require before application of the slab. So the slab is being prepared, and I'm trying to clean the leg before application of the slab by pouring some spirit over the leg. So here, after preparation of the slab, my assistant is applying a roll cotton over the thigh, knee, leg, ankle, and foot of the child. An important step in application of the slab is providing a good layer of cotton so as to make this slab comfortable. An extra layer of padding will be required over the malleoli. So this will be the extra layer of padding that we have on the plantar aspect of the foot. So once we do that, what we'll try to do is we'll try to get the slab and we'll dip it into the water, and we will, so once we put the slab in water, we'll try to squeeze the excess fluid, excess water within the slab. And once we do that, I'll again lift the child's leg and we'll apply the slab on the posterior surface of the lower limb, and we'll secure it with the help of a roll bandage. Now, because of the presence of a good amount of cotton layer, we can tightly secure the roll bandage over the child's limb. An important part is that while during the application of the slab, one has to give a constant traction that I'm trying to give by holding the child's leg and trying to reduce it simultaneously. So another layer of roll bandage is being put across the child's lower limb so as to secure the above knee plaster of Paris back slab. The main motive is to maintain the close reduction that we have achieved of the proximal tibia and fibula. So here you see I'm trying to correct the valgus force, the valgus injury, and by giving a varus mold, keeping the foot in neutral position, and we have to keep the slab in this position till the slab dries out and it becomes hard. So this is the position of the limb after application of an above knee POP slab. So here the child is able to move the toes. So this is the X-ray that we had before reduction, and this is post reduction. Here you can see a beautiful concentric reduction has been achieved, and also the X-ray of the knee prior to reduction and application of the slab, and on the right side we have the post reduction X-ray of the child. So we were able to achieve good close reduction on both the injury sides. I hope you enjoyed the video, and if you did, kindly like, share, subscribe and comment. Thanks for watching.